The few, the proud, we're going to learn a lot together because I'm going to give you insights over 40 years of treating irritable bowel. Actually, I'm 35 years old, but because I took care of so many irritable bowel patients, you see what's going on over here. You know my plan, and it's to share a little bit of humor with you. So an elderly couple had just learned how to text message on their cell phones. The wife was a romantic type and the husband was more of a no-nonsense guy. One afternoon, the wife went out to meet a friend for coffee. She decided to send her husband a romantic text message, and she wrote the following: "If you are sleeping, send me your dreams. If you are laughing, send me a smile. If you are eating, send me a bite. If you are drinking, send me a zip. If you are crying, send me your tears. I love you." The husband texted back to her, "I'm on the toilet, please advise." All right, everybody's with me. Again, this is going to be very interactive. I'm going to give you my experience over 40 years of taking care of these people, and they are challenging. We know they are challenging. How many of you like to take care of irritable bowel patients? Every once in a while, I find somebody who really likes to take care of them. And I'm going to show you the reasons why. Because again, it came to me. I had an epiphany one day, and I wrote down there's a very important slide of why we feel so uncomfortable taking care of irritable bowel patients. So let's move on. Here's my disclosure, and here are the goals: to understand the various manifestations of irritable bowel, to distinguish irritable bowel from inflammatory bowel. And I want to caution against using the letters here. And it's very common for people to start mistaking irritable bowel for inflammatory bowel because they're not using the correct letters. So we want to be very specific, and I see that all the time. So irritable bowel from inflammatory bowel, alarm symptoms. That's one of the most important things I can teach you about today. That will guide you as to how often, how young to do a workup, how often to do a workup. These are going to be very important keys of what you need to look for. What's the appropriate workup? That's always a real big, important thing that we need to talk about. We're going to be talking about with some of the treatments. We'll highlight some of them, and I'm going to give you some tricks that will be helpful for you. Understand how to partner with your patient. That's another one of the important things we're going to learn about today. And understand when to refer the patient. So here are the definitions. Definitions are, and we know the definitions, but again, the scientific definitions are as follows. And why we have to put it down scientifically, how many of you have seen an irritable bowel patient who has consistently, every day, the same symptoms? Right? No, they always have different symptoms. And I can tell you, for instance, and I'm sure you've had the same thing, you see a patient on Thursday, you spend a huge amount of time with them, and you finally give them the medicine. By Friday morning, they are calling you and saying, I either need narcotics, or I'm going to the emergency room, or I'm going to just camp out at your doorstep. And this is what we have because, again, these people back and forth and back and forth. There's very few of these people who have consistent symptoms day by day. So cramping, Rome criteria. And let me tell you a little bit about the Rome criteria. We're up to Rome 4. There's a colleague of mine down in North Carolina who has helped write this, Doug Drossman. And it is to establish some criteria so we can do a lot better research. When we can do better research, we'll be able to help our patients and ourselves to treat them better. Pain, bloating, gas, diarrhea, constipation, and we distinguish constipation from irritable bowel with constipation by pain. So epidemiology. So here's the epidemiology. You can see it right in front of you that irritable bowel affecting 10 to 15% of population. Less than 33% see a doctor. Females twice as likely to suffer from this illness. Why? So here's my first interactive question. Hormones. What else? I'm coming down to hear you. Yeah, they're the prime caregivers in most families. That's exactly right. Okay, from this end of the room, tell me. Why females more? Oh, you're smiling. You already know the answer. Go ahead.
Actually, I can't take credit for it. Men. That was hers.
You got my punchline. Because the punchline was because many of them are married to men. You got my punchline. Okay. You've heard this before. Okay. So irritable bowel with diarrhea, constipation less than 25% of the time. This is the key that I want to share with you, is that we have to define these patients better so we can scientifically investigate them so we'll have better treatments. And again, as I said before, it is very rare to have any pure irritable bowel patient with either constipation or diarrhea. There's always a mixed element. And theories about etiology. So let's talk about it on this side of the room. And we're going to be talking about some etiology. Why do we think? Why do you think it might be happening? Stress. Stress could be one of them, yeah. And? What's that? Diet may be part. I can't throw this over, but I'll owe you one. Actually, you can pass it over. Diet can be it. Okay. Oh yeah, wonderful, perfect. I got something here somewhere, and here we go. This one I can throw to you. Anything else? Small bowel overgrowth. Anybody heard of that terminology? Small bowel overgrowth, bacteria in the small bowel. There's a very important terminology that I want to share with all of you that I just learned about 4 years ago. Nocebo. Everybody knows the terminology placebo. Anybody know what nocebo means? N-O-C-E-B-O. And it's very important because, again, it's going to come back to what we talked about earlier today. Nocebo means a benign product that can potentially cause a reaction. Okay? So I'm going to make you think a little bit of what we said earlier today. So think about it. Can nocebo be part of non-celiac gluten sensitivity? We don't know yet. We don't have that answer yet. So nocebo is one of the terms. And here, let's talk about it. The short answer here is we don't have an exact answer. But we try to approach each one of these directions to try to get better control of the patient's symptoms. Brain-gut signal dysfunction. So we think about antidepressants, right? That's one of the mainstay long-term therapies. And let's see if I can get this going. Motor disorder, hypersensitivity. Small bowel overgrowth, we talked about that before. Food reaction, nocebo. Genetics can be playing a role. And let's talk a little bit about food allergies. Because again, when people come into the office, and you guys have seen that before, if they come into your office and they have a diarrhea that's this big, about 5 inches, it's always single-spaced, you know you got a problem, right? Right? They come in. Here it is, and they'll tell you about each passing of gas for the last year, and you have 10 minutes, and you've got a cardiac arrest in the emergency room, and you've had some really sick people waiting outside. And again, you don't really want to deal with that. I'll tell you how we can work with that. But the things that patients always come to us and talk about is I took this turkey sandwich yesterday. I did fine. But 2 weeks ago, I took the exact same turkey sandwich, and I was sick for 3 days. That is part of that irritable bowel. It's not a food sensitivity because it has to be consistent across the board. That's the key, because people will always tell you the same kinds of things that, reaction one day but not the other. If it's the same food, it's not the food at all. So we can reassure them. So food allergies. We need to, of course, think about sprue. We talked about that earlier today. We didn't talk yet about lactose intolerance, pretty common. And we talked a little bit about FODMAP, which we're going to talk a little bit more about in just a little bit. Here's the essence, okay? If we understand this particular slide, we can be a lot better with our patients. And here's the essence. Again, I said before, it came to me suddenly. I came to the realization, these are the issues that we have with these kinds of people. They are time-consuming, right? We just said that before. We had a patient coming in with a diet diary that you know is going to take a huge amount of time, and we've got lots of other sick people that we need to deal with. They're time-consuming. They have multiple providers. And wherever you come from, they may have been living in Connecticut for about 6 months and then came to you, may have seen me, come to see you. They move around quickly, right? But by the time you want to start doing a test on them, they're already in the next state, in the next coast. High prevalence of social, drug, and mental health issues. My philosophy has always been to give them the benefit of the doubt. So again, I try to help them with this process, realizing that they have drug issues, social issues, etc. In fact, I'm going to give you a great example of how it works. Because again, with irritable bowel, sometimes in years gone by, not recently, they had gone to the emergency room, nothing in the last few years, but they'd gone to the emergency room, they had a minimal workup, and they left with Tylenol number 3 from the emergency room. It's not now, years gone by. And I said, see Dr. Buck within the next 3 days. And the issue was seeing Dr. Buck within the next 3 days. Of course, even at that point, I wasn't going to give them a narcotic. That's the worst thing that you can do for irritable bowel patients. But the issue here was I had the discussion with them, and I would tell them the following. I would tell them, I will not give you a narcotic, but I've got a host of other things to work with you. Are you willing to work with me? In those 5 seconds, if they left going out the door, we knew what they were, what they were really looking for. If they're willing to listen and have that discussion, wonderful. But again, you have to select those kind of people who want to work with you and don't have that hidden agenda. So let's talk a little bit about the next one. The level of distress can make us over-test and over-treat, and I'm going to tell you an example about that. I've got a special one for you, because you were smiling at me before. It's watch out for the pin, but it's the shining American flag. So their level of distress can make us over-test and over-treat. I'm going to tell you an example of a patient that I had seen 15 years ago, and I worked her up for irritable bowel, and she always had these doubts. Dr. Buck, and it's always the whiny voice and the worst kind of patients. Dr. Buck, are you sure I don't have a cancer? It would always be that kind of thing. Yes, I've done a full workup. I feel extremely confident about it. And we have all the answers. We've done multiple tests for you. And we don't have a cancer. And 10 years later, she came to see me with a pathology report in hand to show I have ovarian cancer. 10 years later, I have ovarian cancer. Her words to me were, she wasn't nasty about that. I told you so. I told you so. Some people would say I missed it, and here's my lawyer's number. You'll be hearing from them soon. But no, that didn't happen to me, luckily. And again, obviously, there's no connection. We're all in primary care. We know it takes a huge amount of time to it takes a short amount of time to develop ovarian cancer, and it certainly was not there all that period of time. But the point here is they test us. When they test us, we can over-treat, we can over-test, we can get into all kinds of trouble, especially when we're doing inappropriate testing on people who don't need it. So that's my point here as well. So case 1, talking about difficult kinds of patients. Ed is a 52-year-old malpractice attorney working 18-hour days. Patient with mild abdominal pain, diarrhea 70% of the time. For those of you who like this one, come on Sunday morning at 7. It'll be worth it. You'll have your revenge. Wait, you'll see. Come 7 on Sunday. We got a really great case. Patient with mild abdominal pains, diarrhea 70% of the time, alternating with constipation, occasional blood, mixed with stool past 3 months. History of a quote-unquote hemorrhoid. family history of colon cancer, both mom and dad, at fairly young ages. Last colonoscopy 3 years ago was, which was a good prep and normal. What would you advise? Yeah, see somebody else. I'm going to pay for you to take airfare to Connecticut to see Dr. Buck. So, yeah, that would be a way of approaching that. Any other thoughts? Because again, there's a very important teaching point over here. Repeat the colon. So that's one thought. And again, I like that. Pass this down. Notice which finger it is. So repeat the colon. Anybody, and be honest about it, anybody who would feel about not repeating the colonoscopy? Air contrast barium enema. Go ahead.
I'd have him come in when he had a bleed and do an
Anoscopy, okay. Any other thoughts? I'm glad I appreciate your honesty because, again, that helps us with the teaching point, and the whole point behind this is there's no particular absolute way of approaching these people. There's suggested ways that I'm going to have to protect yourself, but there's no absolute way of approaching that, but you get a couple of other buttons. So let me tell you a little bit about that. Let me tell you about the approach. I would, in particular, not for the remuneration, but because I feel it's the appropriate way to go, do the colonoscopy. And the reason for colonoscopy is we have a patient who has two, and he's fairly young, who has two fairly young family members with colon cancer, 55 and 63. And even though that colonoscopy was done 3 years ago, we're going to talk a little bit about interval cancer. That's when we as gastroenterologists or surgeons miss cancer, which can happen. It varies 3 to 8% of the time.
Is that his first colonoscopy?
And that was his first colonoscopy. That previous one was his first colonoscopy. And my approach would be colonoscopy. Yes, sir? Was he tested for Lynch syndrome? There were no. There was no Lynch syndrome. Okay, there was not in the family, and that's a wonderful question. And tell us about Lynch syndrome. It's familial, right? So pass this down. And Lynch syndrome is something if there was a young family member, and again, it really depends upon the timing. Only in the last few years has it become standard of testing these familial conditions like Lynch syndrome to make sure that it is not passed from family member to family member. And again, with Lynch syndrome or any other condition along those lines, familial polyposis, etc., then we want to be much more aggressive, and that's an excellent point. But there was no Lynch syndrome. So the point here is being aggressive in testing because again we might have missed something, and rarely something might have developed in that short period of time. Go ahead.
This may be an inappropriate question, but is there ever a role for Cologuard, the new Cologuard test?
Is there a role for Cologuard? Excellent question. Cologuard. So tell everybody what Cologuard is.
It's the cancer DNA test.
It's cancer DNA test, which is the short answer to make it really easy. When there's rectal bleeding under these kind of circumstances, no. As a screening test for your Medicare patients, and he is not a Medicare patient, who do not have symptoms, it is appropriate. Afterwards, I'll be happy to tell you a lot more about it. There's a whole bunch of additional information, but the answer here, it's inappropriate under these circumstances because there's rectal bleeding, and that's when you should be going for colonoscopy. So before moving on to the next case, yes, sir?
Capsule endoscopy?
Capsule endoscopy, I'm going to modify that a little bit. It would be capsule colonoscopy, and that's only appropriate and indicated for after you do a colonoscopy and you can't get all the way around. So that's a whole different situation. So that's capsule.
I was thinking maybe of an AVM in the small bowel.
Right. When you have rectal bleeding, and that's, I'm coming around to give this to you. So I'm going to tell you a very important teaching point that you guys all need to know. The important teaching point is that when you're having rectal bleeding, it's bright red rectal bleeding, the chances of having anything from the upper tract are extremely low. There's been all kinds of studies done about this. Again, it's not that it's impossible, but it would be extremely unusual. And most of the studies were that was with heme positive, the heme positive kinds of patients. It's not impossible, but it's unusual to find upper lesions under these circumstances. Let me give you a contrasting kind of case, because this will further elaborate what we need to know. So this is Jolene, who's a 24-year-old patient, history of diarrhea, abdominal pain, past 10 years, has not seen a doctor in 9 years, no rectal bleeding, anemia, or weight loss, no family history of colon cancer, inflammatory bowel disease. And for Jolene, what would you recommend? And there's no right and wrong answers with this. It's really interesting. So what would you guys recommend? She comes to your office. How far are you going to go? Go ahead.
I start with an SSRI diagnostically and therapeutically.
SSRI diagnostically and
Works
okay.
in this age group with no family history.
Okay. So basically how that translates, symptomatic treatment. Okay, so the real question, what I'm leading to, which is very important, and I think you know the answer already, but we need to make sure everybody gets this. Would anybody, and don't feel ashamed to say this because it's a teaching and learning experience, would anybody do a colonoscopy under these circumstances? What's that?
It's a diagnosis with exclusions. This is a lecture about irritable bowel, but at that age, I would kind of educate a little bit that we may have to do it. I don't know if I would do it at 24.
Correct. So the whole point and the information I want to share with everybody, and that's why it contrasts with the first case, I would be very hesitant to do this unless there was something else going on. And I'm going to elaborate for you, and we're going to talk a little bit about that in the future. The alarm symptoms, the rectal bleeding, anemia, fever, weight loss, family history of inflammatory bowel disease, or colon cancer might be indications that we want to do that. On this young patient, no. Okay, so I asked this question 2 weeks ago at another conference, primary care folks just like yourself. So what workup, we heard one opinion over here, which is fine. If you would want to do a workup, what testing would you do other than colonoscopy? Would you do any testing at all? We had one vote over here. And I'm interested to hear what you guys have to say. Lab work, okay. So what lab work?
CBC, CMP, do thyroid function,
Okay.
and probably might not gonna have a good impact on her colon, but lipid profile.
Okay. And that's fine. And that's why this is a great learning experience for all of you guys. And that's fine. The chances of that showing anything are almost zero, okay? And I'm not discouraging. The point here is that there is no set pattern of how we approach these people.
But one way to get some lab on a patient is show that you're interested in their problems, that you're not just blowing them off. And I understand what you're using for the SSRI, but at the same time, what happens if there's something, like physically going on there and it's not just due to stress or depression. So that way, a little bit of that is also to show that you are doing some active things for her and they're not that expensive. And it rules out anemia and some other things that could be
And
going on in a young
right.
woman.
People have expectations. Keep an eye on you. Yes?
Two questions. One, why did she come in to see you? And two, what has been her workup over these 10 years?
No workup.
Well, correct me if I'm wrong. I was taught that irritable bowel is a diagnosis of exclusion and not just one's good thoughts. So every irritable bowel patient should at least travel with themselves the knowledge that they've had their colon and their upper tract looked at. True or not?
No. No.
Wow.
Right. That's changed. The whole philosophy, so that's the essence of this question. This patient does not have the alarm symptoms. She doesn't have, again, the alarm symptoms, or you got what the alarm symptoms are. She does not have the alarm symptoms. So, and we're going to see in a moment what colonoscopy does under these circumstances and how ineffective it is. So the whole point here is, again, you have to do with what your conscience tells you. There, some societies have some guidelines, other societies have other guidelines. The point being, we heard a little bit about the workup. The workup usually doesn't show us very much of anything. When I did this conference 2 weeks ago to primary care folks, Somebody was even talking about stool for leukocytes, because again, that may show a little bit of information. But on a young one like this, that is generally not necessarily the way that we're going to go. The way that we're going to go is according to how the symptoms are and the alarm symptoms. Now, in the general community, is this patient going to end up with a colonoscopy? Probably yes. But I got to tell you, the chances of the colonoscopy showing anything are minuscule, and we're going to talk about this in a moment.
So at what age do you not need just alarm symptoms?
At what age do you not need alarm symptoms? That would be 45 years in the black population, when we would do screening colonoscopies. The 45 years in black population, 50 in non-black population.
So in your experience, irritable bowel is not unusual to present at 45 or 50 years of age?
Irritable bowel can present at any age. The most usual is the earlier, younger age that continued all the way through. And remember, we're talking about a really young individual, and that would be the usual kind of age category that we'd be talking about. If we're thinking about irritable bowel, 40, 50, we're going to think about something else, because it's going to be very unusual unless there's a family traumatic event that happened. Yes?
Along with this workup of blood, I usually tell the patient that, I quote Sir William Osler, medicine is a science of uncertainty and an art of probability. And depending on their concern, I may do some blood work or tell them, if this doesn't work, we will do further workup.
And there's so many...
This age group, yeah.
That reemphasizes what I'm talking about, is that there is no standard of how to approach this. Yes, sir?
Well, you can also think about dietary history, particularly whether or not there's any relationship to dairy products.
Exactly right. And again, I'm not saying that any of these approaches are wrong. I'm just saying,
Just in addition.
yeah, I'm not saying any of these approaches are wrong, but I'm just saying the probability of picking anything up would be minimal. So everybody knows the alarm symptoms. We've talked about that several times already today. Here's the point. So colonoscopy and irritable bowel. And I'm not discouraging you. Please don't get me wrong. I'm not discouraging you. Every once in a while, you get this gut feeling about a patient, no pun intended, that really needs to have that colonoscopy. I'm absolutely not discouraging you from that, but I'm just telling you the statistics out there, which are as follows. Look at that statistic. And that's from William Che. He's one of the premier people in irritable bowel and gastroenterology, who tells us that colonoscopy does not affect the diagnosis in 98.1% of patients with diarrhea. Stunning. So differential, so who can tell me the differential? We're just going to do this real quick. What do we think about? We heard one of the things before early this morning. Go ahead. Inflammatory bowel disease, celiac disease, infection, gastroenteritis, colon cancer, and never forget this as primary care doctors, thyroid. Okay, so there are a whole bunch of things. Inflammatory bowel disease, sprue, lactose intolerance, infectious diarrhea, small bowel overgrowth, colon cancer, microscopic colitis we talked about before, and hyperthyroidism. We should never forget about that. We may be able to save the patient from a big workup.
Metformin and omeprazole.
What's that?
Metformin and omeprazole.
There you go. Wonderful. So tell us about metformin and omeprazole. Tell me. What do you want to share with the audience?
Just had people that tolerated it for a while and then they got new students.
That's exactly right. Wonderful. So everybody heard that. It can happen. So symptoms with sprue, we know that, and we know the story with the majority of sprue patients. And name some features that distinguish inflammatory bowel disease from irritable bowel. Go ahead. Generally, weight loss. What else? Blood. What else? Not necessarily. Mucus is not necessary. Mucus we see an awful lot in irritable bowel. But it is basically reiterating what we talked about before with the alarm symptoms, right? That's why we have them up there. So here's a really important one. Does the intensity of pain help distinguish irritable bowel syndrome from inflammatory bowel disease? Absolutely not. I need courage. I need a heart. I need a brain. I'm over 50. I need a colon rectal cancer screening. Okay. Most of you should have this. Go. Woo. Right. Go ahead. Perfect. Charlie's a 71-year-old gentleman, well until 6 months ago. At that point, he suddenly developed. Any pediatricians here? Pediatricians always get this right. Any pediatricians? No. 71-year-old gentleman, well until 6 months ago, point he suddenly developed profound nausea, vomiting, diarrhea. After babysitting his sick grandkids, needed to be admitted for dehydration. Workup included blood, stools, CAT, normal, colonoscopy, no inflammatory changes on biopsy, and diarrhea much improved. He still has 7 bowel movements a day. What are we dealing with?
Campylobacter.
Stools were negative. What's that? And which leads to, it's called post-infectious diarrhea. So rotavirus, norovirus, any of those things, that's what you usually find in kids. They passed it on. He had this prolonged course. And again, you'll be seeing this kind of patient. Just the whole point of this lecture is to make sure you're aware of these people as well. And how we can help them, you'll see a couple of things. So post-infectious diarrhea, you have that in your syllabus. You treat symptomatically. There's some specialized medicines that can help. We'll talk about that before. So this kind of person, another angry one. And we talked about this angry one before. Yeah, she's got something in mind. And we've all seen them coming in. 33, 2 full workups, irritable bowel with diarrhea, chronic pelvic pain. We used to have somebody in my general area who kept doing laparoscopies on these people. I'd seen a bunch of these people, 3, 4 laparoscopies. It was just horrific. But anyway, the point, she's on Tylenol number 3 for diarrhea and pain, tells you it's the only medicine that works. And we talked a little bit before about how to approach this kind of patient. So I want to tell you a little bit about after I have that discussion. We kind of alluded to that before, about that discussion. Either they slam the door in my face or call me names. But if they stay, or they can slam the door like that, if they stay, we can have discussions like this. I am willing to work with you. Irritable bowel is like an ocean that can sometimes be calm or stormy. But we're going to work on this together. And I've got a host of things that we can talk about, but I am not going to give you your Tylenol number 3. Now, a lot of these people, well, not a lot, some of these people end up on the street and take their stuff anyway and disappear. But the ones that want to proceed and really get to the bottom of it, we're there. And that's part of what I talked about before. You have to have that time, and you have to have the patience with these kinds of folks. What other conditions are associated with irritable bowel? You've seen them, and it can include the chronic chest pains and the headaches, and it just goes on and on and on. Let's talk about case number 5. Jamie is a 46-year-old psychiatrist, irritable bowel with diarrhea for 26 years, and he has questions: what food should I avoid? So anybody have any suggestions? Gassy stuff. That's great. Okay. Any other suggestions? What's that? Sometimes high fat and dairy. What else? I'm sorry, I didn't hear it.
Spicy food.
Spicy food for some people. So, and somebody from this side said something?
I said whatever I heard.
Okay, so they have to take decent diet diaries. We have to educate them about not bringing in 5 inches worth of diet diary. And the answer here is there's no specific answer. We have to spend that time with them and try to figure this out. Remember what I said before about one food, the same food on Monday having no reaction and Friday having a tremendous reaction. That's what we gotta spend time with that. So I want to add a couple of other things. It's the diet foods. That's a very common kind of thing. Diet foods and the diet chewing gums. That can be part of that. and also cruciferous vegetables, gassy vegetables, very important because people will do all kinds of things. If you don't ask them the question, and sometimes if you don't have their family members in there, you're never going to get the truth. I had a patient on a bologna diet, and only when I got his wife in there in the room did I find out that's all he was doing, cold cuts, morning, noon, and night. What causes bloating? Fast answer for that one. We don't know. Don't spend time with it because, again, if you're going to be spending a huge amount of time, there's no exact answer on that, but we treat it symptomatically. Will IBS shorten my life? No. Will my IBS ever get better? I'm looking for a very specific kind of answer. Go ahead. Will my IBS ever get better, doctor? Is that the kind of answer a patient wants to hear? Maybe. Do we want to lie to them? I admire you for your honesty, and because this is a cow rather than a bull, but you can imagine what I would want to say. The answer I'm going to get to this question in a moment. The answer here is I kind of choose a middle road. We're going to work with you. I don't say that it's going to get worse. It's going to get better. I told the same story as I said before. It'll be like the waves in the ocean. There'll be times better, worse, and we're going to work with you. Question over on this side of the room. Okay. Let's move on from there.
You could always tell them, well, are you ever going to have stress the rest of your life? And you can tell me no, and I may tell you, because they're always going to have challenges and stress and different foods, so that's why you could tell them that there may not be a, quote, cure.
I think I want you to collaborate with Dr. Che in writing some of this stuff up. Dr. Che was that reference. That's exactly right. I think that's a wonderful insight. So diet, we talked about these things before, and we're going to move on. FODMAP diet, the only thing that I really want to mention, FODMAP diet, if you decide to do a FODMAP diet, fermentable oligodisaccharides and polyols, it's a lot of the sugars that we get in the foods that we take in any particular day. Here's the list. You have it, and you can look on the internet. Do not attempt to do this diet on your own in the office. It takes an enormous amount of time. We had someone, was it you, sir, that had a patient who was on FODMAP diet for a long time? Yeah, wonderful. That's a rarity. Usually people have tremendous difficulty of maintaining that diet because there are a lot of restrictions. And again, once they're in this FODMAP diet, part of what we need to do is eventually get them back onto a more normalized diet. So just another couple of insights here with a FODMAP diet. It requires staying away from gluten as well because, again, part of that sugar process. And fruits, vegetables, tremendous diet to be able to be compliant with. So here is the essence of what I want to tell you about today. If you don't have the time for this patient, you are not going to succeed. We're going to make it easy. If you don't have the time, you're not going to succeed. Make your patient a partner. Address cancer phobia from the beginning. Sometimes we're successful and sometimes not. Remember the case that I told you about before? I told her there's no cancer. But some people have that fixation that no matter what you say, that there is going to be an underlying cancer. And sometimes they're right. Know that it's a process. It's a collaborative effort. Some of the other tricks that I've worked with, again, many of us work with additional people in the office. MAs, PAs, APRNs, and again, working with this team, it makes it a little bit easier for everybody because, again, everybody has a little bit of a different insight. And again, if the patient is really getting to you, that breaking it up and having somebody else in the office see them and then seeing them back again is a wonderful way of doing that. And that leads to this important point. Look at this top point. Time helps. Uncover sexual victimization. Sexual victimization can occur in 54%. Now, I'm not talking about penetration. I can also add that it is inappropriate talk, inappropriate touch, inappropriate behaviors. There's an enormous amount of this underlying thing. And that's another important thing that I want to share with you in 40 years of experience. And I can tell you there have been a number of patients, and you know, obviously I spend time with my patients. But it doesn't always work because sometimes it's the male-female interaction. And remember what I said before? That sometimes sharing these patients with a PA or APRN in the office. And there was one patient in particular that I'd been working with years and years and years, huge amount of time, and suddenly actually spoke to my MA. My MA, who's female, told me, did you know that Mrs. Such and Such was being beaten up regularly by her grandson, who she keeps at home? That was an insight that was unbelievable. So the point here is that you have to sometimes share that responsibility for that male-female interactivity with the patient, because sometimes you uncover incredible useful information. So family trauma, money issues, drug issues, etc. What's the placebo effect in irritable bowel? Guys are going to get this for sure. Yeah, you guys are getting it. So OTC medicines, anybody's used glutamine? Glutamine. What's glutamine? Anybody? Light in the day. Amino acid. It's an amino acid. Why I'm putting this up for all of you is that you get these patients coming in. You guys have all had this. They want to come in the office, but I don't want to take a prescription medicine. Not that they can't afford the prescription medicine, but because they don't want to take anything that strong. So that's why I'm showing this kind of stuff, because now you're going to have some tricks under your belt, and even if you don't do it, you can talk with your gastroenterologist of these things that you want to try. Glutamine, peppermint. So there's always somebody in the audience who tells me, Dr. Buck, do you know that there's a side effect of peppermint? So what's the side effect? What's the GI side effect of peppermint? Go ahead. Okay, reflux. That's exactly right. So pass this down to my friend over there. That's exactly right. So you have to choose wisely. Here's another trick. Iberogast. Your back is against the wall. You don't know what to do with these poor people. They're still miserable. Iberogast is an herbal medicine that comes from Germany. It's on Amazon. The last time I looked, it was 30-something odd dollars. You take 20 drops and you do 3-4 times a day. And it's a wonderful way of helping to take care in a homeopathic way irritable bowel. And I want to share some insights. So here's some other OTC medicines. We're going to wrap this up pretty soon. Let's talk about Hepar. Hepar is a water product by Nestle. Hepar has a tiny, not a large, amount of magnesium in it. What do you think that does for people who have irritable bowel with constipation? It improves it. That's exactly right. That's what I want to share with you. Kiwi fruit. I was just refreshing my memory with kiwi fruit yesterday, and kiwi fruit's another way of approaching it. Again, if you take too much, there can sometimes be a dyspepsia, but that's another way of doing it, a natural way. So Enterogam. Enterogam, just write this name down. I'll be around over the weekend if you want to know a little bit more about it. It is extremely expensive. It is used for irritable bowel with diarrhea. Your local rep will probably give you one coupon, but when you have to give the patient the second prescription, if they have to pay $300 or $400 for it, they're not going to be very happy. So just be aware that it is incredibly expensive, but it is also used, and it is also used for other conditions, and I'll be happy to tell you a little bit about that for anybody who's interested. So case 6, Harriet C, 62-year-old female, irritable bowel with diarrhea. She wants to recommend a probiotic. What do you suggest? Okay, we're kind of getting in the right answer. Okay, so let's move from there. What I wanted to tell you about is that with probiotics, even though Bifantis that you mentioned that you voted for up there is pretty effective, and I certainly have given it myself, There have been no side-to-side comparisons, and the whole point is understanding and working with probiotics is a very, very difficult field because, again, especially with irritable bowel, it is complex because the symptoms are always changing. But again, if you're working with one probiotic and you need to move to the next one, don't be fearful about it. The one question I was going to ask you is yogurt. People always ask about yogurt. And how much yogurt do you think you need to give to have a good probiotic effect?
1 cup.
1 cup. Anybody say more? More. And the price is right. Yes, come on down. And why do you think that is? It has to do with the stomach. Acidity. Acidity, because again, the lactobacillus inside will be destroyed by the stomach acid, so you have to give large quantities. So in a patient that has to take 3 cups of yogurt a day, just have them be aware that maybe they're going to get a little bit of looser stools. So let's continue here. So loperamide, diphenoxylate, bile acid, these are all things that you guys are well familiar with. Loperamide abuse can result in which condition? That's just ripped from the headlines these days. Go ahead, go for it. Okay, I'm going to answer while you're still voting because it can also cause euphoria and syncope. Be aware of that as well. So the answer is all of the above. And it has been even more so than in years gone by in recent time abused. Anybody use Lotrinex? No. Let's move on from there. So my approach for difficult cases, I empirically always start a gluten-free diet. Pancreatic enzymes. Why might I even think about pancreatic enzymes? I heard something from the right side. Pancreatic insufficiency, because again, we don't always have an easy diagnosis with pancreatic insufficiency. That's my particular approach. I think lots of other gastroenterologists may want to go along those lines. Amitiza you're familiar with, Linzess you're familiar with, and why I'm even mentioning these medicines, there's no magic pill. Sometimes it's combinations, sometimes it's taking away one and adding another. The one thing that I would say about Rifaximin is that it works well when it works. However, it is another one of these expensive medicines. You get a coupon, patient is happy. They get money. Some of these places, it's an even trade. You get the medicine for free. But then the next time when they need it, they're calling you, doctor, how come you made me spend $250 on this medicine? So be aware of that. Antidepressants. My colleagues over here were mentioning very wisely about that earlier, and it is one of our mainstays of long-term therapy. Is number needed to treat of 3 a good thing or a bad thing? It's a very good thing because some of the medicines that we're working with right now in any area of medicine, number needed to treat 15, 20, 25. It's unbelievable. So we know it's effective. It's not FDA approved. The reason that it's not FDA approved, none of these companies wanted to go through these huge studies. But we give it out like water. Every gastroenterologist gives that out. You guys are probably giving that out for irritable bowel as well, but it's not FDA approved. It doesn't mean that we can't do it. And of course, the lower dose than usual for depression. And we use the appropriate medicine depending upon the side effects. So amitriptyline causes constipation. There we go. Makes people want to fall asleep. Cheap as dirt. We don't have to worry about coupons because it's so inexpensive. So antidepressant pearls are the use of antidepressants decreases the sensitivity. Many of these patients have psychiatric comorbidities and use the medicines to the patient's advantage. Alternative viewpoints, use the medicines that work. I never say no when people are telling me about alternatives unless I feel it's going to be a worrisome proposition. The missing pieces, very limited head-to-head studies between psychotherapy for irritable bowel and a combination of psychotherapy and pharmacotherapy. So, and again, most parts of this country, getting a patient to see a therapist, it can be months, it can be years, right? Probably in your neck, five years until you see the next therapist. So, we're left handling these people, and you got to do something in the meantime, and that's the whole purpose of this talk. Repeat workup. We know the repeat workup. If there are these alarm symptoms that we talked about, real life versus statistics, and that's what I talked about before. Some of these patients coming in, there's just something in your mind that just says, let's be more aggressive than these alarm symptoms that Dr. Buck mentioned today. Go for it. I'm just giving you some basic ideas, but it doesn't mean that that's absolutely the way that you have to practice.